Welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy. When this video is a continuation of Express Revision course for periodontics. And before we get started, make sure you subscribe to the channel and click on the bell icon so that you don't miss any of the exciting videos. And today we'll be talking about the periodontal instruments. So these periodontal instruments, they are basically used for removing the calculus. And we know that when the plaque get calcified, it forms the calculus. And we have to do the scaling and the root planning because this calculus and the plaque, they are the major factors contributing to the periodontal disease. So it is very important that we remove the disease part. So either it is a pocket, so removing the pocket epithelium, or curating the gingiva, or doing the scaling and the root planning. So subgingivally, supragingivally. So if we are going above the gingiva, we have covered, we call it the supragingival calculus. So removing the supra and subgingival calculus. So definitely the instruments which we use to remove supragingivally are different from the one which we used for the subgingival. So periodontal instrument, earlier the stainless steel instrument was the most common choice, but nowadays we have got the high carbon steel instruments that are available and they are in superior quality. So this video or lecture we are going to talk about the instrumentation such as the periodontal probes. So guys, periodontal probes are the basically probes. So they are a kind of a explorer with a blunt tip, and there are gradations in the probe. So there is calibrations, or we can say marking in millimeters in that probe. So once we penetrate this probe into the gingival sulcus, so suppose this is the gingival sulcus, and once we penetrate this probe, we can actually measure the depth. So we can measure that how much is the depth of the gingival sulcus. So that is the main use of a periodontal probe. That means it is used to locate, it is used to measure the and even mark. So we have got certain probes which mark also periodontal probe. Periodontal pockets. So that kind of probe also we will cover. Then we will be covering about the explorer. So guys, I hope that all of you have seen explorers, and especially we also use this explorers to check the caries as well. So these explorer are kind of like this instrument, which are sharp tip, right? With a mouth mirror we use it, these explorers. So explorer, we use it to locate the calculus in perio, and even we use in the cons for locating the caries. So guys, this video we are going to cover the scaling, root planning and all the curettage instruments. So all the instrument which we use to remove the plaque, or which we remove the calcified plaque, which we call it the calculus, or are there any calcified deposits if they are present on the root surface. So suppose in case of removal of an altered cementum from the subgingival root surface, or if we want to debride the lining of the pocket. So if we are talking about that, we are curettaging. So there are certain instruments which we use for scaling and curettage instruments. So that also we are going to cover in this part of the video. So the scaling and curettage instrument, guys, we will be covering the scalers. So scalers, you know that all of you have seen the scalers. When we do the manual scaling, when we are doing the supragingival calculus removal, then we use this Seckle scaler. So U1530 is the universal one which we use it for supragingival scaling. So that is, you must have heard of Hufredi always we use in India. Most commonly we use if we are doing the manual scaling, we use the universal U1530 supragingival calculus removal, we use this universal Seckle scaler. And also we will be covering the curettes. So guys, these curettes, they are fine instrument and we use for subgingival scaling and when we are doing the root planning, and especially if you want to remove the pocket lining. We know that pocket, once there is a pathological deepening of the gingival sulcus, there is a pocket. So we have covered already that about regarding the pocket. So what is the pathology in the previous part of the lectures, that what causes a pocket formation and what happens, there is an inside lining. So guys, this is just the deepening of the gingival sulcus is what do we call the pocket. So if there is more than 4 millimeters, we call it the periodontal pocket. So there is deepening of the gingival sulcus. So this sulcus get deepens, and here is the ulceration of the lining sulcular epithelium which we see. So what we do is we remove this part. We remove this part of the epithelium. So for that purpose we use the curettes. So they are also used for supragingival or most of the time subgingival scaling. Supragingival we use the sickle scaler. So these scalers, the sickle one, we use it for the supragingival, and for the subgingival guys, supra, and for subgingival we most commonly use the curettes, and then we also have got the hose, chisels, and the fine scalers that also we will cover in this part of the video. So what are these instruments basically? Because there are so many instruments, and most of the time if you have no idea about, if you have no knowledge about the instrument, they look similar, all the instruments to you. So also we will be covering the file scalers. And guys, there are certain plastic instruments also. So plastic instrument are the one which we use for the implant instrumentation, if we want to check pocket for the implant, and we also have got titanium scalers for the implant. These are the manual one. What are the machined ones are our sonic and the ultrasonic instruments. That also we will cover in this part of the video. And ultrasonic, the ultrasonic is far better than the sonic one. So that also we are going to cover. And guys, endoscopes. We will also cover the dental endoscope, or you can say periodontal endoscopes. So endoscopes also will cover in this part of the video. And guys, the cleaning and the polishing instruments. So what are the instrument after we do the cleaning and the root planning? So scaling and the root planning, what happens, there is rough surface on the cementum, on the root surface. So we have to make it smooth so that there is no plaque accumulation or no calculus accumulation further on. So in order to do that, we, after doing the scaling and the root planning, we clean and polish the tooth surface or the root surface, whatever it is. So the cleaning and the polishing instruments we are going to cover in this part of the video. That we will cover the rubber cups, the brushes, dental tapes for interdental scaling. It is just like the dental tapes are just like the floss, but they are like a thin sheet rather than the thread. Also we have got air powder abrasive systems in the scaling and the root planning, I mean the cleaning and the polishing instruments. That also we will cover in this part of the video. So guys, if we see the parts of periodontal instruments, so we have got two instruments, two kind of instruments in the picture here. The first one you can see, it is a probe, it is not explorer. Now what is the difference here? First of all, the tip is blunt. If this tip is fine, then we call it, if it is like this, then guys we call it the explorer. So this is not an explorer. And also guys, if you can see here, there are some marking graduations. So calibrations are present in millimeters. So this particular instrument is a periodontal probe. So you can see here there is a blunt rounded tip. There are calibrations in millimeter, and all of these are, so this is the handle guys. First of all, parts we are going to cover, right? So this is the handle. If you can see here in the handle, there are some serrations in this area. You can see here this area has got serrations. So we call it the knuckling. This is the knuckling, and this knuckling is in order to provide a grip to the instrument so that there is no slipping of the instrument. Suppose if we are, because we are working in a wet environment, we have got the contact to the saliva. So in order to maintain a nice grip, there is serrations which are present on the handle of this instruments. And you can see here guys, this particular area is the shank, and the working tip is this one, or working end you can say. This is working end are present with the calibration in case of a periodontal pocket. So based on that, there are different type of probes which will be covering: Marcus color coded probe, and Michigan O probe, then we have WHO probe, then we have got Williams probe, then Michigan O probe with the William marking also we have got another kind of probes. So all these probes we are going to cover in the continuation of this video itself. And next one, if you can see here guys, we have got a typical periodontal instrument which looks more like a scaler. So it has got a blade here, this particular part is the blade, and this particular part is the shank. Other side also guys, we have got a blade here. So this is the blade, then we have got a shank, and in between is the handle. And if you can see here, the same pattern of serrations or knuckling is present as well as in the periodontal instrument, which looks more like a scaler. So if there is a long shank which is flexible, if the shank is long guys, what will happen? This, we know that length, more the length, more is the flexibility. So if there is a larger shank, so if the shank length is increased, that means the instrument is more flexible. And if we have to do the supragingival scaling, suppose if we have to remove lot of hard calculus, so in that case we use rigid shank scalers for removing the calculus. So in order to apply greater amount of forces to remove the calculus, so all these kind of scalers we use the rigid shank scalers. So guys, how do we use this periodontal probe? Suppose this is the surface. Now this here is the crown, we have got CJ, and we'll make a gingiva. So this is the gingiva. Now what do we want? We want to check the pocket. So what we have to do is, we have to take this periodontal probe and we have to insert this periodontal probe guys into this epithelium. So once we insert this periodontal probe into the epithelium, gingival sulcus, not the epithelium, I'm sorry. Once we insert into the gingival sulcus, we measure this. We measure this marking. So guys, we take this periodontal probe, insert into the gingival sulcus, and we measure with the help of these marking. So we see that what is the depth of penetration of the periodontal probe, and therefore we check this how much is it is, and then we calculated the depth of the periodontal sulcus, the gingival sulcus, I'm sorry, depth of the gingival sulcus. If it is more than 4 millimeters, we have covered, that is our pocket. In a normal clinical gingival depth of gingival sulcus is 2 to 3 millimeters, and histological depth, this is the clinical one. Now with this all we have covered guys in the gingival chapter. So first part of the video of this lecture series we have already covered, and 1.8 millimeters is the histological depth of the gingival sulcus. So if we cut the tooth, we take the histological cross section, then we will find that there is a 1.8 millimeter in the depth in the gingival sulcus which is present. So this we have covered. Now we know that how to measure a pocket. Now that we know this depth is more than 4 millimeters, so we have got markings in the probe. So based on these markings guys, there are different kind of probes which are available in the market. So this one you can see here is the Marcus color coded periodontal probe. So in that there are calibrations in 3 millimeters cross section. So in this we have got markings in the 3 millimeters area. So 3 millimeter sections we get the markings in case of a Marcus color coded probe. As you can see here, color coded, that means this is color coded. So there are areas which are coded with a color with the Marcus color coded probe. Next one you see here is the Universal of North Carolina probe. So this is 15, if you can see here it is written 15 probe. So that means there are 15 marking which will be present in this. So there it is a 15 millimeter long probe with the markings at each millimeter, and there is a color coding at 5th, 10th and 15th, so multiple of 5. So there are coding which are present at 5th, 10th and 15th is the color coding, and guys, the marking are present at each millimeter in case of this probe, Universal of North Carolina 15 probe. Next one we can see here is our WHO probe. So guys, WHO probe, World Health Organization probe, as you can see there is a O word. So remember that O, that means it looks like a ball. So if you see ball at the tip, that means I have marked a 0, so that means it is a WHO probe. Always remember this first part, that there is a ball. So 0.5 millimeters of ball which is present at the tip of this WHO probe. So this is a whole around different probe because it has got a round ball which is present at the tip. No other probe has got a ball. So rest of the probe you will see markings, but you will not find a ball. So if in case of a image based question comes that you can see a periodontal probe, you can see a probe with a marking. So or I can say in easy language, if you see a blunt explorer with the markings, that means it is a probe. And if you see a ball at the tip, that means it is a WHO probe for sure. And you will see the millimeter marking at 3.5, 8.5 and 11.5 millimeters. And you can see here there is a color coding which is present. So this color coding is from 3.5 to 5.5 millimeters. This is the color coding in case of a WHO probe. Now I think that you guys can appreciate very easily a WHO probe. You can appreciate very easily Marcus color coded probe because there are calibrations at 3 millimeter in the Marcus probe, which we have covered. The first one we have covered, and then there is a North Carolina 15 probe. So 15, you know that 15 millimeter is the probe length, and every millimeter there is a marking present. Next one guys is our most favorite Williams probe. So the marking in the Williams probe are 1, 2, 3. Now you can see that 4 is absent, and then 5, then you can see the 6 is absent. So 4 and 6 marking are absent in case of Williams probe. Then there is 7, 8, 9 and 10. So there are up to 10 markings. Now why specifically 4 and 6 are missing in case of Williams probe? This is the question which is most frequently asked by the students. Then one student asked me once, ma'am, why not 5 and 7? Why is only 4 and 6? Now guys, as I told you that more than 4 millimeters is what do we call the pocket. So the 4 millimeter marking is the upper limit, right? So this is the starting limit of a periodontal pocket. So more than 4 if it is, we call it the periodontal pocket, right? So that is the upper limit. So this is missing. Again, if it is more than 6 millimeters guys, then we call it the advanced periodontitis, right? So that also will give us idea that what stage, what is the stage of the depth. So that means we will know that if it is more than 6 millimeter, that means the patient has got some kind of advanced periodontitis. There is nothing is written in the books as for sure, but like this is our way to express or to think about it. Suppose if you insert the periodontal Williams probe into the pocket, now you know that 4 is missing. So if it is a less marking, less than that, if it is 3, suppose you cannot see the 5th marking after the insertion of the probe into the sulcus, you know that it is deeper. So this is the Williams probe which we use it the most frequently. So when the periodontal probe is placed within the gingival sulcus, there are no areas of marcation. So helps us get the abnormal pocket depth if there is any. So this can be a reason we can say for the missing of 4th and 6th number. So next one guys we have is the Michigan O probe. So Michigan O probe, see guys, Michigan O probe, there are 3 markings. So marking at 3, marking at 6 And you can see here, this one is closer. So this is 8 millimeters. So 3 markings are present, 3, 6 and 8 millimeters. So guys, that's about the probe. We have covered the Marquis color coded probe with the 3 millimeters of section. We have covered Michigan O probe with the Williams marking, and Williams marking we know that 6 and 4 are absent, and Michigan O probe. And then we have also covered the WHO probe, which has a ball at the tip, which is 0.5 millimeter, and marking at 3.5, 8.5, 11.5. And also in the furcation, we have covered that we measure the furcation with the help of a neighbor's probe, which looks like this. And the neighbor's probe also has got the color coded, which we have covered in the pocket part of the video. So it has got 2 markings. So one is at the 3 millimeter, 6 millimeter, 9 millimeter and 12 millimeter marking. So color coding between 3 and 6 and 9 and 12 in case of our neighbor's probe. So neighbor's probe. So this is about the probes. Also we'll be covering some plastic probes. So plastic probe, we use it for the implants. Implants, we cannot put the stainless steel for probing. So in order to measure the pocket depth around the implant, we use these plastic probes. So they also have got marking at 3, 6, 9 and 12 millimeter, same as the neighbor's probe. So neighbor's probe and plastic probes both have got the marking at 3, 6, 9 and 12 millimeters. And also guys, one more probe is there, which is the Florida probe. Now this Florida probe is a titanium tip, and it is basically an electronic probe. So what it does is, it has got an indicator for the force which is applied during the pocket depth. So the 0.25 Newton of force is applied with the help of this probe, and the precision is about 0.2 millimeters. So this was about the probe. Now talking about the scaling and curettage instrument. So scaler, if we talk about guys, this is a typical sickle scaler in the diagram over here. It has got a flat surface and it has got 2 cutting. This lateral surfaces are the cutting surfaces for a sickle scaler. So what we do is, we take this scaler and suppose this is the tooth and here is our calculus deposit. So suppose here is our calculus deposit. Then we take this probe over this tooth surface. One second guys. We take this probe over the tooth surface and then we just try to remove it. So we try to remove this. So with the help of this sharp cutting edges, we try to remove the supragingival calculus, which is above the gingival margin, because this is used for supragingival because the design is such that it is easier to engage the above the gingival calculus. So the shape of the instrument makes the tip stronger, and we have talked about this has got a rigid shank. So once it has got a rigid shank, then we can apply more forces. So this is a sickle scaler. We engage it over here. So guys, we engage it over here and then we try to remove the calculus by using a pull stroke. So we engage it and then we pull it. We pull it down. We pull the scaler down. Now with that scaler, it comes the supragingival calculus. So this typical diagram is a diagram for universal 1530 scaler. This is the one which we use the scaler as in the Hufridi, and these are both the ends. One end is this one, guys, one end is this one and another end is this one. Now we have got sickle with a straight shank. This straight shank sickle, we use it for anterior teeth and the premolars. One with a contra angle shank, we use it for the posterior teeth. So let's write the anterior and the premolars. And then the contra angle, we use it for the posterior teeth. So this is the scaler which we use if we are doing the manual scaling. If we are doing with the machine, then we use the sonic and ultrasonic. Now talking about the curettes. Now, curette is basically designed for removing supra and subgingival both the calculus. But curette we most commonly use to remove the lining of the pocket wall. So, the ulcerated pocket epithelium. So, guys, we have to again make this diagram. So, suppose there is a deep pocket and this particular part is the ulcerated part. Now, we have to remove this. We engage the scaler. And we remove this part of the pocket lining. So this is the main purpose of the curettes. So we remove the pocket lining, the soft tissue lining of the pocket as well as the subgingival surfaces. So we can also use for the subgingival, let's write the subgingival calculus. We can also use it for supragingival as well. But for supragingival, we have got the sickle scalers, right? The supragingival calculus. And for curettes, we use it for subgingival. Guys, we have got curettes for subgingival, hose, chisels, file scalers. All these instruments, we use it for subgingival calculus. For supragingival, we use this sickle scaler, which we call the Hufredi, right? The universal scalers, 1530 scalers. There are also other scalers which we can use, like there is a jcat series 1, 2 and 3. They have the medium size blades. We also have Navite 2 posterior scaler, which is a thin designed, used for moderate ledges of the calculus removal, which is basically for the subgingival. But again, curettes, we are talking about the curettes are a type of scaler that are used for moderate calculus removal. So it can be both subgingival, the supragingival, but majorly we use it for the subgingival calculus. So there are two kinds of curettes, guys. One is the two types. One is the universal one. One is the universal, which is shown in the diagram over here. This one is the universal scaler. Another one is the area specific. That means we have got specific scaler for specific area of a tooth surface, which we call it the Graceys scaler. So these Graceys curette, the Graceys curette are area specific curettes. So they are designed for specific area of the tooth, and all the curettes share the common elements, like they have got a rounded back. So guys, they have got the scalers are like this. If you cut a cross section, so what you will find that they have got a rounded back and the lateral cutting edges. So these are basically the cutting edges. So let me show you these curettes, how these curettes are designed. So guys, this is a typical curette. This is a typical curette, and these are the cutting edges. These are the cutting edges of the curette. So you see that there is a face, there is a back, which is the posterior part. And if you see here, if we cut this from over here, and if you see this section from this view, you will find that there is a rounded back, there is a face which is shown in grey color, and the lateral surfaces you can see here, this one, the cutting edges. So the one which I have shown in the green one. So these are the cutting edges. So they are very sharp, and they remove the subgingival. They also remove the pocket lining. They also remove the subgingival calculus. So this is a typical diagram for a curette. Now we have two kinds of curette. One is the universal curette. Another one is the area specific curette. First we'll talk about the universal curette, the one which is shown in the diagram over here. So this universal, as the name suggests, that means it is universally acceptable. That means this curette is designed for all the tooth surfaces. So this universal curette is again same as it is. So it has got a round back and it has got the lateral cutting edges. Now the difference between the area specific and the universal curette is that it has got a 90-degree angle. So over here you can see that there is a 90-degree angle to the face. So it has got a round toe and back and two cutting edges. These cutting edges, let's make from the green color again. So these are the cutting edges of the curettes, and which cuts the lining epithelium, which cuts the subgingival calculus, so the lateral surface. Now again, this universal curettors also got the anterior and the posterior one. So anteriorly, that means we are going from the anterior part, from the front teeth, from canine to canine. So to scale the facial surfaces, we place the toe of the blade towards the proximal area, and the handle, guys, we keep it parallel to the tooth surface. So suppose if this is the maxillary anterior teeth, this is the patient's lips. So these are the patient's lips, suppose upper lip, like this lateral view I am showing you. So we make this parallel to the long axis of the tooth, and then we apply strokes like this, strokes. In the strokes we apply, and from the midline of the tooth surface to the proximal surface we go, then we switch the working ends and repeat for the surfaces away from us. Again, the likewise we use the posterior universal curette. Now for the posterior we go from the distal surface of the tooth, that means the last posterior teeth, and we go towards the mesial surface, like this we go. We apply the strokes, and then we turn toward the mesials to the scale, and then we scale the buccal and the mesial surfaces. First we go to the distal surface, then we go to the mesial surface, and then we switch the ends and do the same for the lingual area. So first we go buccal. So first, guys, suppose if this is the arch, then this is the buccal area. First we go distobuccal, then we go mesiobuccal, then guys we go to the lingual areas. So this is how we use this curettes. Now this was about the universal curette, right? So this is the universal curette. Then guys we have got the Graceys curette. So Gracie curette along with the Hufridi, there is a in early 1940s there was a Dr. Gracie. So he designed curettes for every specific tooth surfaces. They are different for tooth, but again different for surfaces of the tooth. So they will be different for these Graceys curette are different for the facial surface, for the lingual surface. Then like that, these are some area specific. That is why we call it area specific, right? And guys, the difference between universal and Gracie is that, see, universal this is 90 degree. So the Gracie blade is offset from the terminal shank at 70 degrees. So this is 70 degrees. So guys, now what happens? This particular area, suppose I'm gonna again draw a tooth surface from this color, and then the gingival sulcus. Suppose this is the gingival sulcus. We put it in the pocket epithelium. We want to remove this particular, this is not visible, this particular calculus, suppose. So what happens? We can easily remove this calculus by this pulling motion. So if we pull this curette, it will take away this chunk along with this. So likewise, now here the epithelium is not touched. But if you do the same with the universal one, we are going to make the same diagram for the universal one, and if you try to insert it into the pocket, now what will happen is, guys, it is going to rub this surface area also. So it is very easy to use with the Gracie curette, and that is the reason they have made this Gracie curette with the specific areas, so that the action, the work we are doing is easier for us. So it basically creates only one cutting edge. If you can see here, only this cutting edge here is the one which is in use. So this is referred to as the lower edge because it is on the lower side. So the shank design is different for each of the Gracie curettes. Now if you can see here in the diagram over here, we have got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So like that we have got also 15, 16 and 17, 18. We also have got 15, 16 and 17, 18. So all these are the area specific Gracie curette. And let me tell you the function of these Gracie curettes. So 1, 2, 3 and 4 are used for anterior teeth. 1, 2, 3, 4 and again 5 and 6 are used for anterior plus premolars. Then talking about 7, 8 and 9, 10. So 7, 8 and 9, 10. Both of these curettes we use for the posterior teeth and the facial and the lingual. Facial and the lingual surfaces. Now guys, 11, 12 is the one which we use it on the mesial surface. So you have to just write 2, 11 like 1, 1. 11 is 1 and then join both of these. So it will become the mesial. So again I am telling you now 11, right? We are talking about the number 11, 12 Gracie curette. For 11 you just have to write 11 and then combine both of these 11. That makes a M. So that will be 11, 12 is our mesial surfaces of the posterior teeth. So mesial surface of the posterior teeth. Then we have got 11, 12 and then we have got 13, 14 guys. Yes. 13, 14 guys is the distal one. And 15, 16 is basically the modification of 11, 12. So 15, 16 is the modification of the 11, 12 for the mesial surface of the posterior teeth. Because we know that 11, 12 is the mesial surface. That is why I told you we have to always remember that 11, 12 is the mesial one. So just write 2, 11 and then combine it. So that will be mesial surface of the posterior teeth. So when 11, 12 is combined with the acute angled 13, 14 shank. So shank of 13, 14 and blade of 11, 12 will make 15, 16. So likewise 17, 18 is a modification of distal one. Which is the distal? 13, 14. Right, 13, 14, see here. 13, 14 is the one which is distal one. So modification of 13, 14 which is for the posterior surfaces, posterior distal surfaces, which has got a terminal shank which is elongated by 1 millimeter. So shank is plus 1 millimeter for 17, 18, but the blade is minus. So blade is shorter by 1 millimeter for 17, 18, which is the modification. So minus 1 millimeter. Shank is plus 3, it's not 1, it's 3, plus 3 millimeter, and blade is reduced by 1 or shortened by 1 millimeter. So let's just draw in the diagram over here. The first one we made it for the green color. So we are talking about 1 and 2, right? So 1 and 2 are the anterior teeth facial tooth region, right? So this is the 1 and 2, anterior teeth and facial tooth surfaces for the anterior teeth. So canine to canine, this is 1 and 2. And 3 and 4 are the palatal surfaces. Let's take green only, but some different shade I'm trying to find. Okay, maybe this is going to work. So this is 3 and 4. This is, guys, 3 and 4. Which is again for the anterior surface, but for the anterior teeth, but for the palatal surface. So this is 3 and 4 anterior teeth, the lingual surface, or we can say the palatal surface, any of it. Now talking about 5, 6. You remember 5, 6 is for anterior plus premolars. So I'm just going to make 5 and 6 over here. So 5 and 6 for the premolars. 5 and 6. Now guys, talking about the posterior surface. Now if you remember, 7, 8, 9, 10 are for the posterior teeth, facial and lingual region. So 7, 8 and 9, 10, right? But only the facial and lingual. So 7, 8, 9 and 10. So 7, 8, 9 and 10. Now we have got 11. Remember, 11 is, we have to write 2, 11 and then combine it, which will become the mesial surface of the posterior teeth. So posterior mesial surface are these surfaces. It's better that we use this one. So this is the posterior mesial surface, which is our 11 and 12. So what we have to do is, we have to combine 2, 11. I mean 1, 11, 1, 1. So this is our 11, 12. Now 13, 14 guys is our distal surface. So this is the distal surface, is the 13, 14. Now 15, 16 and 17, 18 are the modifications for 11, 12 and 13, 14. Now I hope that you guys are clear with the Graceys curette at least. So 1, 2, 3, 4, 5, 6. 1, 2, 3, 4 for anterior, 5, 6 for premolars, 7, 8, 9, 10 for the buccal and the, so for the buccal and the lingual surfaces, 11, 12 is for the mesial surface, and 13, 14 guys is for the distal surface. So these are the area specific Graceys curette, and the angle is offset 70 degrees. So this is the Graceys one, Graceys curette. Angle is 70 degree for this. For the universal, we have got an angle of 90 degree. This is the difference between both of them. So you have to remember it that universal we have got 90 degree angle, Graceys we have got 70 degree angle, and again you have to remember the numbering, and especially the mesial. Always remember the mesial one, which is the 11th one, 11 and 12. So this is the 11 and 12. So if we want to do the scaling of entire dentition full mouth, we have to use this particular, this set of the Graceys curette. So whole of these Graceys curette, we need to use it for the deep scaling, for root planning, or if you want to remove the pocket lining, so we call it the periodontal debridement, you have to use all these curettes, all the Graceys curettes. So what is the difference between the universal and the Graceys curette? This we have to remember it. We have just now covered the differences between the, in detail depth about the Graceys curette and the universal curette. So what is the area of use? What is the area for both of these curettes? So area of use for Graceys curette, we have got the specific area for the specific curettes, right? We have covered that 1, 2 we use it for 1, 2, 3, 4 we use it for the anterior teeth, and 5, 6 we use it for the premolars, then 7, 8, 9, 10 for the posterior teeth, facial and lingual region. 11, 12 you remember 1, 1, then combine it and form the M. So 11, 12 is for mesial posterior. 13-14 is for distal posterior. 15-16 is the modification of 11-12, in which there is a blade of 11-12 and there is an acute angle shank of 13-14. 17-18 is a modification of 13-14, which is the distal one, and in that we remove the blade diameter -1 and then we elongate the shank by 3 millimeters so that it is easy to reach. So these are the specific areas and we use specific curettes for these areas. So that is why we call the Gracie curette as the area specific curette. So this is the area specific and even the surface is specific. So specific area and the specific surfaces, which we use it in case of the Graceys curette. But if we talk about the universal one, there is one curette which we use for all the surfaces, all the areas. So only one curette is used. Now guys, what is the use cutting edge? If you remember the Gracie curette, so the Gracie curette is basically like this, right, which has got offset blade angle of 60 to 70 degrees and it has got only one cutting edge. So there is only one cutting edge. But if we look at the universal one, so it has got two cutting edges. Which one? The lateral ones. So these two cutting edges. So cutting edge for the Gracie curette is only one, which is the outer edge. But for universal curette, both the cutting edges, both the lateral edges are the cutting edges, right? Now talking about the blade angle, which we have just now discussed. So the blade angle. Blade angle for the universal is 90 degree. So the face of the blade is beveled at 90 degrees to the shank. And for the area specific, it has got an offset blade of 60 to 70 degrees, beveled at 60 to 70 degrees to the shank. Now talking about the curvature of the blade. So curvature of the blade. Blade is curved for the Gracie curette, is curved up and to the side. But the universal curette, blade curves up, not to the sides. So blade curves up and to the side as well. But in case of universal, the blade only curves up, not to the sides. So this is the difference between the Gracie and the universal curette. So this we have covered, that there is a cutting edge in the universal, both the cutting edge. So cutting edge, if one is there, then it is the Gracie. If both are there, then it is the universal, right? So guys, next talk about the after 5 curettes. Now this is a standard curette which we were talking up till now. In after 5 curette, there is increase in the shank. So elongation of the shank. As you can see here, the shank is up till here in case of a standard curette. And if you see this after 5 curette, there is increase in the shank. So this much increase in the shank for the after 5 curette, which is 3 millimeters. 3 millimeters shank is elongated, and this is done in order to provide the better clearance around the crown and the superior access to the root contours, and if there is more pocket depth. So suppose if there is 5 millimeter or more of the pocket depth, then this after 5 Gracie curette can be used in case of the deeper pockets. We use this after 5 curettes.
So there is increase in the shank, and also guys the blade is thinned. So this, oh god, so this is the diameter of the blade, right? Now what happens, this blade is thinned over here, so not much of the thinning is there, but the blade is thinned by 10%. This is in order to give an easy gingival insertion, and it reduces the tissue distension. So this is after 5. You have to remember that after 5 curette there is shank is elongated to 3 millimeters to provide better clearance for the deeper pockets. The next one we have is the mini bladed curette. So the mini bladed curette, as you can see here in the diagram over here, we have got the middle one, which is the standard. This is the standard, and we can see here the shank of the standard is up till here. Right, but there is again no, this is okay guys, this is the shank for the after 5, shank of after 5, which we have just now covered.
And here is the shank for the standard one. So as you can see here, the standard curette and our, this is guys after 5. And here we have mini bladed. Now if you can see here, the shank of mini bladed and the shank of after 5 is somewhere elongated 3 millimeters more than the normal or the standard one. So the standard one shank is here, but now we can see that the after 5 and the mini blade have got the elongated shank. So basically this mini blade shank is elongated 3 millimeters to the standard curette, and also you can see that same to similar to after 5. Now what is the difference between after 5 and the mini bladed? The mini bladed, as the name suggests, it has got mini blade. So that means the blade of this mini blade is smaller. So it has got 50% shorter blade. Now as you can make out from this diagram, so the length of the blade is half of that of after 5. So the mini blade has got the shorter blade for access to the smaller roots. So for small roots. And for the narrow pockets, for narrow furcation. So basically for narrow pocket. So this is the difference between the mini blade and the after 5. So after 5, which we have covered just now, that after 5 there is a elongation of the shank to 3 millimeters for the better clearance, and mini blade shank is equal to same as the after 5, which is elongated, but the blade is shorter here. So if we want to make a difference between a standard one, so standard one has got everything standard. So there are certain sizes 1, 2, 3, 4, 5, 6. Then 7, 8 and 9, 10 are for posterior. Up to that this was anterior and premolar. So 1, 2, 3, 4 anteriors, 5, 6 premolars, 7, 8, 9, 10 we have covered that it is for the facial and lingual surfaces. 11, 12 is for, again guys, 11 remember mesial, right? And 13, 14 is for distal, and the next then 17, 18, 15, 16 are the modifications. We have also covered the after 5 one. So after 5 has got the elongated shank by 3 millimeters, but the blade width is decreased. So the width of the blade is actually decreased by 10% for after 5, and the same is with the
mini blade. So it is also decreased width. We are talking about the width of the blade. That is decreased by the 10% for same as goes for the mini 5, and the after 5 and mini 5, both the shanks are longer by 5 millimeters. But the blade length, guys, for the after 5 is same. See, this length is same. So the blade length of standard is equal to the blade length of the after 5. But if you see the blade length for a mini blade, it is smaller. So it is 50% smaller. It is decreased. The blade length is decreased for the mini 5. So this is the, guys, difference between all three. Now I hope that you understand the difference between a standard, after 5 and the mini blade. So if we make the difference, now this is a standard shank, and after 5 is plus 3 millimeter elongated shank, and shank for mini blade is again plus 3 millimeter, which is elongated. Blade width, we have also covered that. Blade width for the standard one is standard, but blade width for the after 5 is decreased by 10%. So decreased by 10%, and for mini 5 is also decreased by 10%. But if you see the blade length for after 5, guys, it is normal, but for mini 5 it is decreased by 50%. So this is the difference between all three. So guys, next one we have is the langer and the mini langer. Now langer and the mini langer, what we have to do, we have to combine both of them. So the standard Graceys shank design, because they have got different shank for different design for different areas, plus the blade of universal curette. Right, very easy. So the standard shank of standard design of the Gracie plus 90 degrees angle of the blade of the universal curette. So that makes a langer and the mini langer. So it has got 1, 2, 3 and 4. So langer 1 and 2 is basically Gracie's 11 and 12. Easy. We just have to remove the first digit, first letter. And langer 3 and 4 is the Gracie's 13, 14. So if you remember, 11, 12 is the mesial one. So the langer 1 and 2, we use it for the mesial, plus here we use the distal as well. But this one is, we talk about the mandibular teeth, mandibular posterior. And for 13, 14, we use it mesial and distal surface of the maxillary posterior. So this is the difference between the langer and the Gracie's curette. 5, we also have got the 5, 6, and there is a mini version of 5, 6. So 5, 6 is the mesial and distal surfaces of anterior teeth. And this is just the mini version of this. Next, guys, we have the Schwartz periotriever. So periotrievers, as you can see, is the name itself. Perio means it is a periodontal instrument. Trievers mean it is going to retrieve. So if any broken instrument is there in the pocket, suppose if there is a broken piece of instrument which is there in the pocket, so suppose this was the broken instrument in the pocket and it is not coming out, so in that case we use this periotrievers, Schwartz periotrievers, which retrieve the broken instrument. So it retrieves the broken instrument. And you can see here they have got a long blade which you put in the pocket, and there is a contra-angle tip.
which is used to put in the pocket. I mean, for use in the furcation areas. So basically, they are highly magnetized instruments, and they are set of two double ended instruments, and they are designed for removing the broken instrument tip from the pocket. Next one, guys, we have here is the, you can see here, this is a plastic probe. So we have plastic instrument. So as you can see here, blunt and markings, that means this is a periodontal probe. Which one? The plastic one. So this is a plastic periodontal probe, and if you remember that we have already covered that there are marking at 3, 6, so color coding between 3 and 6, and we have 9, 12. So these are the marking which are present in the plastic probe. Why do we use this plastic probe? What is the need of the plastic probe? So if you are checking with the implant or any abutment material, so in that case, for implants, we have got two options, guys. One is to use a plastic instrument, another one we can use as the titanium instrument, so that we avoid the scarring or we avoid any damage to the abutment, any damage to the implant. In that case, we use the plastic or the titanium instrument. So implacare implant instruments, which is basically of Hufridi brand only, these instrument, they are very nice. So the tip is the plastic, and the bottom in the Hufridi there is steel, so you can autoclave it. So this is an instrument which is of Hufridi. So they have got steel handles, and they have got different cone tips. So there are different tips of the cone which are available in the market. Next one, guys, we have are the hose scalers. So hose scalers are also used for scaling of the instrument. Now, what is the difference between a sickle scaler and a hose scaler? You must be wondering. So, guys, hose scaler, it looks like this. So basically, this scaler is like this, guys. As you can see here in the diagram over here, it is bent. So this scaler is, guys, bent. As you can see, bent at the working tip. So this is the working tip. And there is a bent at the working tip. This is a 99 degrees bent, which is present for the hose scaler. So the cutting edge is formed at the junction of the flat terminal surface with the inner aspect of the blade. And as you can see here, there is also beveling which is present. This is not straight. So the cutting edge is beveled also. See, it is not straight. So if you see it from like this, it is not straight. It is basically beveled at 45 degrees. Like this. Beveled at 45 degrees. So the purpose of this hose scaler is to do the scaling of the calculus. Now, if you can see here in the diagram over here, it has got two contact point at the tooth. So there are two points which this instrument make to the tooth surface. And one really nice feature, guys, as you can see here, this back is blunt. Now, because this back is blunt, it is not harming these tissues of the sulcus. So, this is a good advantage of this hose scaler, is that there is no damage to the adjacent tissue because the back of the blade is rounded. So, hose scaler are used for scaling of ledges or rings of calculus. For scaling of the ledges or the rings of the calculus. And the blade is slightly bowed so that it can maintain a 2-point contact on the convex surface of the tooth. So next one, guys, we have are the files. So these are the files. Now they have got a series of blades on the base. Blades on the base. And their purpose is to fracture or to crush. So the purpose is to crush the calculus. So what it does, we are just breaking the calculus. So we are fracturing the calculus. If large deposit of calculus are present, then we use this file to fracture that large pieces of the calculus, and file can easily gog. And the disadvantage of the file is that it roughens the tooth surface. So after we use the file, so the disadvantage is that when we rub this, it roughens the tooth surface, roughens the surface. And because of that, we have to use along with that some curettes. And this is the reason that we don't use these files anymore for fine scaling and root planning. So we usually use the mini blades, mini bladed curettes once we use this file. So after using the file, we use this mini blade curettes. And files can also be sometime used for removing any overhanging restoration if they are present. Next one, guys, we have are the chisels. So chisel scalers. As you can make out from the tip itself that these are the chisels. So they are basically designed for the proximal surfaces. What we do is we engage this proximal surface. So basically we use this in the anterior tooth region. And you can see from the zoom diagram over here that it has got two ends. One of this is a curved one. So there is a curved, and another one is the straight one. So what we do is the chisel which we are inserting at the facial surface, basically the anterior tooth region. So slight curve of the blade actually is helpful in stabilizing in the proximal surface, and the other part we use it to engage into the calculus and then cutting off the calculus. Next one we have are the quitinfurcation curettes. So guys, these are the half moon radius, and they are hose with a half moon radius, basically modified hose, you can say. So there are two types, the BL1 and MD1. So the one which is 0.9 millimeter blade width, and another one is the bigger width, so which is the 1.3 millimeter width blade width. So that are two, BL2 and MD2. So these are the quitinfurcation forceps. Now if we see that this is a diagram showing the instrument grasp. So what is the most effective, or we can say the most stable form of instrument grasping, which is our modified pen. So this is a modified pen grasp. As you can see here, it is making 3-point contact with the instrument. So there are 3-point contact. So guys, this is a tripod contact, we call it, right? Now talking about the angulation and the strokes. So what is the angulation for insertion of the instrument. So suppose guys you have got a curette, and once you are inserting the curette, what we do is we insert the curette at the 0 degree angle. So insertion is just parallel. Insertion it at 0 degree, then we slightly tilt it. Then we tilt it for the scaling and the root planning. Up to 45 to 90 degree. This guys you have to remember, it can be a question which can be asked for your exam. So the insertion is 0 degrees, that means we just have to insert it, there is no action which is going on. And for scaling and the root planning, the correct angulation can be between 45 to 90 degrees. Now talking about the stroke, this was the angulation. So what is the kind of a stroke which we use? So if you are using probe or if you are using explorer, then we use the exploratory stroke. Basically, this stroke is very light feeling stroke. And also we use the stroke with the probes, periodontal probes, for detection of the pocket or for detection of the calculus, in fact. So basically this is used with a probe and the explorer. Next one we have is the scaling stroke. So scaling stroke is the one which we use it for scaling, for subgingival or for supragingival. So what do? We engage the scaler and then we pull it towards us, right? So we pull it towards us. So that is a short and powerful stroke. Third one is the root planning stroke. So which is for smoothing or planning the root surface. So that is not a powerful stroke because then epithelium will be damaged. So that is moderate to light stroke, which is also pulling. So moderate to light pulling stroke. So this is also pull, this is also pull. Now guys, talking about now if we are talking about angle, we talked about angulation, right? So let's talk about the sharpening angles also. So if you are sharpening the instrument, then what should be the angle? So the angle between the face of the blade and the surface of the stone should be 100 to 110 degrees. So the sharpening angle is 100 to 110 degrees. Now guys, most of the time what happens is we don't know what is inside the pocket because that is quite actually not visible to us. So there is another generation which is, we call it the dental endoscope. Now what is an endoscope? Endoscope is basically a system which has got attached to a CCD, which is the charged coupled device, and there is a video camera. So basically what happens that there is a fiber optic wire, and this wire guys, it get incorporated along with the probe and it gives a picture on a monitor. So we can actually see what is inside this. So there is a fiber optic wire which goes along with the periodontal probe or any ultrasonic instrument, and they produce an image on a monitor screen. So whatever is there subgingivally, we can actually see even small minute amount of calculus is there, that is also visible. So basically what it provides, a clear visualization into the subgingival areas. So either it is a pocket or it is a furcation area, we get a clear picture. So this is a charge coupled device, and using this device
we can nicely debride the root, we can nicely clean it. And also this camera has got a magnification up to 24 into 48x. So this is the magnification. We can zoom it and see even a minute amount of plaque or a calculus if it is present. So guys, this is a perioscopy perioscopy system, which has got a fiber optic cable, and this fiber optic cable is 0.99 millimeters. I think that is not visible. So this is 0.99 millimeter diameter fiber optic cable, which is fitted, and it is in fact reusable, so there is no harm in using it. This perioscopic instrumentation, it gives a clear picture into the subgingival pockets or any furcation. So I hope that's about the today's lecture. Next video will be covering the cleaning and the polishing instrument as well as the surgical instrument used in perio. So the scalers, then we'll be covering the ultrasonic instruments, the sonic instruments, and all the surgical instruments. So we will be covering the incisional, excisional instruments, then we'll be covering the scissors, the blades, so the Kirkland blade, knife, the Orban's knife, and all the type of surgical blades, that also we'll be covering in the next part of the lecture. And also we'll be covering the electrosurgery part. So all the surgical instruments which are used in a periodontal surgery will be covered in the next part of the video. I hope that you guys have enjoyed this lecture, and if you have enjoyed this lecture, then give it a thumbs up. Also guys, comment in the comment section below, because this motivates me to put more videos, more interesting and more informative videos for you guys for free. And also you can check out the link provided in the description box below, that will take you to the notes of this particular video and more interesting notes like this. And also you can support us on Paytm as well as on PayPal to make more free videos of this kind. So guys, till then, keep reading, keep learning, stay motivated. All the best for your exam. I'll see you soon in the next video.